Catherine, thank you very much for your very kind introduction. And I'd like to thank the British Academy of Restorative Dentistry and in association with Tipton Training for giving me this opportunity to present this webinar. This is my second webinar that I've ever done. It's a very weird medium, I find, for lecturing. I've always presented lectures to a live audience in the past, but this is obviously the way of the future. And it seems rather weird sitting at home giving a lecture to a computer and being on my own without any interaction from anyone. But like I say, this is my second webinar. I really did rather enjoy the first one, which was on failing implants and some of the causes of failure of implants. And of course, implants are held in bone. Strangely enough, we need to understand what bone does and how we need to look at bone and what the bone signifies. And it's important that we understand the biology of bone, how bone reacts to infection, how bone reacts to injury, how bone reacts to healing when we extract a tooth, what happens when infection arises around the apex of a tooth, when the pulp dies, when we remove the tooth, when there's an infection there, etc., etc. So what happens when we have a healed socket and we decide to drill an osteotomy to place an implant? What happens when we've had significant atrophy of that bone? What happens to the alveolar bone, which is totally different to the basal bone? We shall look at implant site classification. We're going to look at how bone is laid down, the osteocytes, the undifferentiated osteocytes, the function of the mucoperiosteum, and look at bone biology in such a way that we can understand how we can utilize it to our advantage. So, what we know is that implants actually change people's lives. And when I look at this lady, the smile within her eyes is significant. This woman, I mean, you look at the eyes and she could be my potential future ex-wife. But then you look closely at the smile, and my office, my surgery, is quite a large surgery, and she walked in through the door, which is probably 10 feet away from where I sit, and the smile is really off-putting. And the chances of her having a low smile, a low lip line, were zero. This was showing from all of 10, 20 feet away. And you've got to ask yourself, what went wrong for this case to be so appalling, such a significant failure from an aesthetic standpoint? And you've got to ask yourself, would I have done the same? And in my opinion, I know full well that I wouldn't have ended up mutilating this really attractive woman to give her a result that was this appalling. And you've got to think, where did this case go wrong? And you can see from the soft tissue, the mucogingival line, where the attached mucosa is, that she's had multiple surgeries in the past. She's probably had some apical surgery, done badly, I presume. I wasn't around to see it, so I couldn't really comment on it. But you can hazard a guess that the implant abutment interface in this situation is far too deep in relation to the cemento-enamel junction of the adjacent teeth. So really, the planning of this case has been abysmally poor. And what gives you the clue that you've got far too deep an implant abutment interface is that if you look at the papilla on the mesial of the upper right central incisor and the mesial of the upper left lateral incisor, it gives you a clue that there is some bone at these points, which means that you've got a bridge that you could build up to, that bone is feasible to build into that region. So the bone is missing at that point. And the saying that Garber, Team Atlanta, always came up with, that the bone sets the tone and the issue is the tissue, but maybe the clue is in the screw. So to transform a case that is as complex as that, which means explantation, grafting, reimplantation, and changing a few things to get a result like that is quite significant. But to do that, you've got to understand what the composition of bone is. Now, bone is a living tissue, and it's composed of 70% of a mineral compound and 30% organic. And when you understand that the minerals in this is tricalcium phosphate, mainly hydroxyapatite, with other minerals incorporated. And you'll remember hydroxyapatite from years and years ago, historically, those implants that were coated in hydroxyapatite, which had an incredible attachment of bone to the surface. Unfortunately, the attachment of the hydroxyapatite to the surface of the titanium was very, very poor, and their success rate was appalling. The organic component of bone is mainly type 1 collagen. The other organic components are mainly cells, growth factors, and bone marrow, etc. Growth factors like BMPs, bone morphogenic proteins, etc., and various cells. So what we know about bone, looking at a scanning electron microscope here, is that it is a dynamic tissue. What do we think when we look at a dynamic tissue? Well, essentially, bone is a connective tissue which contains a mineralized substance to it. It's a complex and dynamic tissue which is actively changing and self-repairing. 10% of the body mass that we have is renewed every year in the adult human. So it's constantly changing within us as we just sit still. This process is called bone remodeling. I want you to watch this video. It's a very interesting video that was produced by Dentsply, and it's called Cell-to-Cell Communication. Let me press go on this and hope that it functions.
Our Bones are a marvel of natural design, continuously rejuvenating through a finely balanced equilibrium of bone resorption and new bone formation. A truly miraculous structure is formed which follows the lines of mechanical load. Sometimes, however, the unexpected happens. A drill intrudes and destroys the naturally sculpted bone. Blood vessels are torn and a major defect is created, quickly filling with blood. The titanium implant is inserted where the tooth was previously lost. At first, the only force holding the implant in place is mechanical friction. This is called primary implant stability. Osseointegration, or secondary implant stability, requires a highly complex sequence of additional biodynamic processes. This is facilitated by finely tuned communication between the main actors of wound healing, the cells. The blood immediately perfuses the surgical site, providing the cues for subsequent healing. Within seconds or minutes, ions and serum proteins such as albumin, fibrinogen, and fibronectin begin adhering to the titanium surface. Next, the bleeding is stopped by blood platelets, also known as thrombocytes. When they are exposed to collagen and other proteins from the traumatized tissue and implant surface, they aggregate and close the ruptured blood vessel. Platelets release various messenger substances for cell-to-cell communication, such as thromboxane, which promotes platelet aggregation, or PDGF, platelet-derived growth factor, which stimulates the cell division of fibroblasts. Fibrin monomers spontaneously cross-link, forming a fibrin network. The blood permeates the wound space, forming a provisional matrix. It also adheres to the implant surface. This blood clot has tremendous importance as a provisional matrix for subsequent bone healing processes on the implant surface. During the early stages of healing, immune cells clean the wound of the fine bone chips, tissue debris, and oral bacteria that remain following the surgical procedure. In the first step, bradykinin from the platelets increases blood vessels' permeability. As a result, the endothelial cells move apart very slightly. On the inside of the vascular walls, endothelial cells promote the attachment of polyorthonuclear leukocytes from the bloodstream. These leukocytes, also known as PMLs, squeeze themselves through the gaps between the endothelial cells. Once they have digested the basal lamina using proteases, they are free to enter the wound. PMLs chemotactically navigate toward the wound along a molecular concentration gradient. These molecules include bacterial proteins, fibrinopeptides, and pro-inflammatory interleukins. Upon arrival, they kill bacteria through the release of reactive oxygen species. PMLs also release highly digestive enzymes such as collagenase and elastase. The wound then proceeds through an uneventful healing process, or a toxic wound environment develops with elevated bacterial counts and toxic byproducts, potentially leading to wound breakdown and implant loss. PMLs can call for auxiliary support, for example, through the release of monocyte chemotactic protein, or MCP1. Macrophages respond and are the next actors to arrive on the scene. They too eliminate bacteria by phagocytosis. Tissue debris is taken up and biochemically degraded. macrophages synthesize pro-inflammatory cytokines and proteases. Macrophages dominate during the late inflammatory phase. Using endiogenic inhibitors for digesting proteinases, the so-called TIMPs, macrophages help stop the round of tissue destruction started by PMLs. This preserves the matrix proteins and proteoglycans in the wound, which in turn protect important growth factors. Messenger substances such as VEGF, PDGF, and FGF stimulate fibroblasts and angiogenesis, which initiate the proliferative phase. Fibroblasts appear on the third or fourth day. They migrate into the wound using amoeboid movements. They synthesize the protective and stabilizing components of the extracellular matrix, such as collagen, elastin, and proteoglycans. The low oxygen concentration in the tissue affects both macrophages and endothelial cells, stimulating them to create the intracellular transcription factor hypoxia-inducible factor, or HIF. Subsequently formed VEGF, in turn, influences perivascular cells. Perivascular cells are mesenchymal stem cells found on blood vessels. They migrate along the VEGF gradient into areas of low partial oxygen pressure. Here, they form new blood vessels that finally integrate into the existing vascular network. Angiogenesis restores the oxygen supply and forms the foundation of bone healing. Starting around day 7, activated osteoclasts attach themselves to the fracture edges of the residual bone, resorbing it and creating space for bone healing. However, this will initially reduce the primary stability of the implant. Here, the osteoclasts dissolve the bone using hydrochloric acid and proteases, releasing BMP, TGF-beta, and PDGF from the bone matrix, which in turn initiate the formation of new bone. Perivascular cells not only create new blood vessels, they also migrate toward existing trabeculae and to the implant surface, where they differentiate into new osteoblasts under the influence of BMPs from the dissolved bone. The adsorbed proteins, such as fibronectin, have a crucial influence on the attachment of bone progenitor cells to the implant surface. The osteoblasts form an organic matrix that is mineralized by incorporating calcium phosphate. Under the optical microscope, bone is visible on the implant surface. Under the electron microscope, though, a thin protein layer is seen between the bone and the titanium surface. Mechanical stability is ensured by interlocking with the surface of the implant. At the end of the first week after surgery, woven bone is formed at the implant surface. This in turn promotes increasing secondary stabilization of the implant, making up for the progressive loss of primary stability. The formation of woven bone concludes the proliferative phase of wound healing. Orderly and coordinated bone remodeling restores the stability of the site. Load adaptation is of pivotal importance in this context. Initially, woven bone will have grown in the valleys of the implant surface and parallel to it. After remodeling, most bone will be structured perpendicularly to the peaks of the implant threads at right angles to the implant surface. The architecture and organization of this bone becomes trabecular. The structure is thought to be directly responsive to forces imposed through the implant to the interfacial tissues. This is made possible by the synergy of osteoblasts and osteoclasts. The osteoclasts, activated by the osteoblast messenger RANKL, resorb the woven bone. The osteoblasts then lay down highly organized lamellar bone. The work of both cells is mainly coordinated by the osteocyte and its own messengers, such as sclerostin. Lamellar bone structures are formed. Similar to the arches and vaults in a Gothic cathedral, they absorb the stresses of occlusal load. We are back at an efficient trabecular bone meshwork, perfectly adapted to the new situation. Osseointegration, a highly complex biodynamic process of cell-to-cell communication, is completed.
There we go. I think that's a fabulous video, actually, explaining how all the various cells and the various derived growth factors allow angiogenesis to take place once we've inflicted a wound onto the site, and allows blood to get back into that area. One of the things that you're thinking about once you've prepared an osteotomy, what if my osteotomy doesn't bleed? And sometimes you see that. When you do, you've got an issue, you've got a real problem, and you've got to try and entice the area to bleed, because placing an implant into a non-bleeding site is a big problem, and you are likely to see a failure in that place because you are not going to get the kind of issue, the kind of sequence of events that you have just seen going on there. So let's look again at what the phases of bone healing are. The first phase that we are looking for is hemostasis. We obviously need to get that site to bleed. We need to interfere with the blood vessels. We need to get the platelets breaking up, and they need to start the process of bleeding going on into our site. Once we've had bleeding into the site, we need the macrophages to come out, and there's a picture of the macrophage, the inflammatory phase to get rid of any bacteria that may be in the site. This is vitally important. Some people are advocates of placing an implant into an infected site. I am not a big fan of doing that. My philosophy is that you remove a tooth that's infected and you tend to leave it for 3 to 4 months. Yes, you are going to lose some bone, but my feeling and views are that you tend to go for a partial bone healing, that you are far better off to go and do some regeneration rather than overwhelm the inflammatory phase and potentially create a loss. When you do create a loss, you then have a huge potential problem that the regeneration that you are going to have to do when you lose that implant is significantly more challenging than had you allowed that site to heal, and whatever regeneration you would have had to do is far easier to do than had you have carried on. So the inflammatory phase, treat it with caution, keep it minimal, keep it under control. Then you have the proliferative phase. Now, this is a significant phase that you've got to think about. If you are doing a lot of immediate loaded cases, think about the proliferative phase. This takes place at around about 7 days. This is where you've got woven bone, very weak bone, Try not to interfere with the restorative at this stage. I've seen some people rushing a case, taking the provisional restoration off, interfering with things. If it's broken, if it's fractured, then you have no choice. But always remember that the 7-day mark, your primary mechanical stability is compromised. You've got woven bone, which is very immature. If you look, we'll talk about it in a moment, contact and distance osteogenesis. It's you know, you've only got little thylapods that are attached to the surface of the implants at this stage. And you've got to think that this isn't a significant attachment. The osteoclasts are there, they are working to remove what bits of dead bone that you had. And this proliferative phase is the phase that takes away your mechanical stability. So always think about it. The hemostasis is part of the healing. The inflammatory is part of getting rid of the rubbish, the disposal service. The proliferative is the part where the primary stability disappears and it starts giving you the secondary stability. So think of it in that, the 4 phases, and then we come to the remodeling phase. And this is an ongoing process, and it doesn't really start to kick in until probably around the 120 days, where the occlusal forces are starting to be applied. We are putting forces directly onto the implant itself, onto the restorative side, and we are really encouraging that bone to work. Of course, if we are off-axis loading and we are creating forces that are not natural for that implant, then we are going to create a problem. And we all know that occlusion is a dynamic process in the same way that bone is a dynamic substance, that you've got to check your occlusion regularly. Check it every recall that you do, because teeth are held by a suspension system, the periodontal ligament, whereas an implant is an ankylosed metal structure within bone, and there is no forgiving within that. So make sure that off-axis loading, interference, etc., isn't allowed to play a part in being a destructive force. So you've got to make sure that the occlusion is a constructive force for your implant. So remember the 4 phases that you have: the hemostasis, you've got your inflammatory phase, proliferative phase, and the remodeling phase. And use those phases within your treatment plan. Consider when you're going to do what at whatever stage that you're looking at. If you're an immediate loader, a prolific immediate loader, consider the proliferative phase within your treatment planning. That's significant and is very, very important. Let's look at the osteoclasts and the osteoblasts. Look at the different sizes of them, etc. The osteoclasts are significantly larger than the osteoblasts. They are the resorbing cells, the enzymatic and acidic, whereas the osteoblasts are more alkaline. Think about new bone formation, whatever materials that you are going to use for your augmentation. Think about whether it's acidic or alkaline in its composition, and the degradation, resorption of the bone. If you're going for something acidic, whether that is going to be constructive in your regeneration process. Vitally important decisions that you will have to make in that decision process. let's look at one of the bone diseases that we are really quite concerned about these days, osteoporosis. If it mostly occurs in women, postmenopausal phase, get a DEXA scan carried out. Very common feature today. Very often we see it with oral bisphosphonate therapy, and it's prescribed to inhibit the osteoclastic activity. I'm seeing a lot of people coming in with oral bisphosphonates these days. Oral bisphosphonates tend to be okay. We look at the BIONJ, bisphosphonate-induced osteonecrosis of the jaws. Robert Marks over in Miami has probably published most work on this. Patients who are taking oral bisphosphonates may be at risk of developing necrosis of the jaw following exposure to tooth extraction or the placements of dental implants. When you see a case, it is quite devastating to see. I've had 2 cases in practice. It is very, very destructive. And they were on oral bisphosphonates. The most commonly prescribed bisphosphonates that you've got to look at are the Actonel, alendronic acid, Boniva, Fosamax. The concern is for alendronic acid is twice the dose of the other 2 drugs, and it has been associated with a higher incidence of BRONJ or BIONJ. Patients taking these can be treated like any other patient taking for implant therapy. The advice that I would give would be to remove whatever teeth that are affected and monitor that patient with quite specific notes and photography. I wouldn't be considering immediate implant placement on these patients at all. I would have a staged approach. Once you see that once the tooth has been removed, that the healing is uneventful, I would proceed to implant placement. And I think you tend to find that with oral bisphosphonates, you will get very, very few problems. Your issues will come when you're looking at IV. And the critical issues are 2 years or less, you'll get normal bone healing. More than 2 years, the risks start to become a bit more significant. When you're looking at any of the alendronic acid, it affects the mature osteoclasts as well as the osteoclastic precursors in the bone marrow. It usually takes 2 or more years for the drugs to affect the mature osteoclasts and reduce effect of osseointegration significantly. And if the patient continues taking the alendronic acid, you'll get a slow or an impaired recovery from the precursors that will threaten your osseointegration. So long-term use, be extra cautious. The first option that you look at on long-term use is to look at the serum markers. Get a blood test carried out by their oncologist or whoever's treating their osteoporosis. It's usually cancer therapy. So second option after consultation with their physician is to stop taking the alendronic acid, but bear in mind the half-life is bloody ages. Let's look at the mechanism of osseointegration. Jed Davies at the University of Toronto did some fascinating work on mechanism of osseointegration. And here you see an osteoblast with little filopods attached to the surface of the roughened surface, looking at a scanning electron microscope of the surface of titanium. And the conclusions he came up with is there's two types of osteogenesis taking place, and there's distant osteogenesis, where the bone cells are actually layered on old bone surface. The blood supplies the cells between the bone and the implant. New bone is actually formed and positioned on the surface of old bone, and there is no direct bone contact to the implant surface. Whereas if you look at contact osteogenesis, the bone forming cells are attracted and caught by the implant surface. The blood supplies the cells between the bone and the implant. A new bone is formed on the implant surface itself. So you've got osteoblast differentiation. Phase one, you have initial contact with the surface, and you've got anchorage with little filopods. You see this microscopically. These little filopods actually attach to the various roughened surfaces, the little grooves, little holes that you have on the surface of the implant. And that's how the little osteoblast attaches to the surface of that implant. Phase two is these then squash and spread out to form little lamellipods, which gives a far more solid attachment of the little osteoblast to the surface of the implant. So it squashes itself onto the surface of the implant. Phase three, you get the external spreading of the bone cell, the osteoblast, spreads out, the lamellipods spread themselves onto the surface of the implant until you get onto phase four, where you get the full spreading and the flattening of the bone cell. So you've got mechanisms then of healing and regeneration. So if we look at this, repair is the healing of an injured tissue, which leads to the formation of that tissue that differs in morphology or the function from the original tissue. Regeneration is the healing that leads to the complete restoration of the morphology and function. The healing of bone tissue includes both regeneration and repair phenomena, depending on the character of the injury. So the factors that are going to interfere with our bone healing are failure of vessels to proliferate into the wound. Obviously, you look at the hemostasis and the inflammatory, proliferative and remodeling phases. If we have improper stabilization of that coagulum and the granulation tissue formation in the defect, then that's going to interfere with that healing. If we have ingrowth of non-osseous tissue with a high proliferative activity, then that will interfere with our healing. And then if we have a bacterial contamination into that defect, all of those factors, if you think about the 4 phases of bone healing, if any one of those 4 phases are overwhelmed by any of those features, then healing is not going to take place. Osseointegration cannot take place. So you've got to consider all of those factors whenever you do a guided bone regeneration, whether you do a block graft, whether you place an implant. all of those features will come into the bone biology and the bone healing at every single stage of what we do. So let's have a look at the bone formation that goes on in an extraction socket. This is the work that Jan Linde did, published in Clinical Periodontology and Implant Dentistry, 4th edition in 2005. Let's look at day one of what happens in an extraction socket. We've all taken teeth out. We've all seen what happens on the first day, and what we want, obviously, and if we obviously don't get a dry socket, we want bleeding and we want a blood clot. And if we look at the slide, the histology slide, we can see where the bone is, we can see the periodontal ligament, and we can see in the center of that we have a blood clot form. If we look at the next slide, which is 3 days into the healing process, we have clot formation, we have wound cleansing. So we've gone from hemostasis, we're looking at the inflammatory stage. So if you look closely at the histology, this is going to be full of macrophages, which is going to be cleaning the wound out, the wound cleansing phase of what's going on. So what we are seeing is that the breakdown of the periodontal ligament, and you can see that on the bottom left of the screen, and various parts up the socket, and there will be a lot of activity going on at this stage. If we go further down, day 7, we are going to see vascularization, granulation tissue, and more inflammatory cells going on. Now, this is part of the cleansing of this socket in order for us to see a proliferative phase. So hemostasis, inflammatory, proliferative phase, where we are hoping that we will see some bone formation going on, and this will be lamellar bone that we will see before we get, woven bone that we will see before we get to lamellar bone. And this will occur around day 7. Hopefully, you won't see breakdown of the clot, breakdown of the wound cleansing, or the granulation tissue. So as we progress onto day 14, we will see connective tissue and the woven bone formation going on in the apical region. Now, this is within a 14-day period. Now, if you were thinking timing of implant placement, would you be happy to go in at a 14-day period? My preference is to wait something in the region of 3 months. Why? Well, as we go further down this pathway, looking at the timeline, new woven bone, this is something in the region of about 21 days. New woven bone with primary osteons. You can actually see that towards the bottom of the screen. There's a beautiful one there just breaking down into the virtual bottom right towards the center of the screen there. Nice osteon going on there. You can see the new woven bone happening nicely in the center, bottom of the screen. Then we look at day 60, woven bone with bone marrow going on and lamellar bone formation happening everywhere. That is fabulous. Look a little bit further down the line, day 90, and that's lamellar bone with bone marrow everywhere. Fabulous site to place an implant. So can't get any better than that. Look at day 120, 3 months down the line, you've got a fabulous area. You can even see various blood vessels in there towards the center of the screen. And if you look about 1.5 centimeters to the right of the H, there's a blood vessel there. So you've got angiogenesis going on at its best. lots of remodeling going on. You can see all the phases of bone healing, bone biology at its best. So, you know, you've got the ideal opportunity to place an implant. So everything is working nicely. So let's look at implant site classification, a classification that Team Atlanta came up with. And if we look at this situation, you can see that the socket is totally intact. You can see the bundle bone around the tooth there. You can see that the mucoperiosteum is completely intact. Respect the mucoperiosteum, because that is your friend, and understand what its function is, because the mucoperiosteum has several functions. When you reflect the mucoperiosteum, keep it intact, because you should know what its functions are. Most people will think that it's a blood supply to the cortical bone. Well, it is, but it also has other functions. And it is, in fact, a secondary blood supply to the cortical plate. Not only is it a secondary blood supply to the cortical plate, it also has a very significant function in that it is, it's divided into two layers. It has an inner cambium layer, which is full of undifferentiated mesenchymal cells, which become osteoprogenitor cells, which have an osteogenic potential, which is there for remodeling. So it, you know, it remodels the bone, and it also is there for attachment of connective tissue and muscles, ligaments, etc. And it also forms an electrochemical barrier. When you remove the mucoperiosteum, you are actually creating a problem in that that bone will shrink. So this is a difficult situation to remove that tooth and place an implant. People think it's easy, but it isn't. So be careful with it. When you've removed a tooth, you are going to lose a little bit of that bundle bone. So be very careful again when you're in that situation. This is an easier situation to deal with because you know you're going to have to do some regeneration. And this is an overdenture situation or a major bone graft. So this gets even easier. So how do you get a level of stability 10 years down the line to the bone of that nature? I think the key for stability long-term for an implant, you've got to look at the work that Marco Esposito did. How much bone you require. You need to have a volume of bone that is stable. That is a prerequisite, both mesially, distally, buccally, palatally, or lingually. And if you have that, and you have a good implant abutment connection that is stable, then I think you're halfway there. But I think the key is volume of bone and good density of bone, and treat the bone with respect. Don't burn the bone. Don't put too much pressure on the bone that you have pressure necrosis. Don't overload it, and don't load it too soon. You know, if you're immediately loading, treat that with respect. Immediate loading of a single tooth, you've got to keep it out of occlusion until it's ready to be treated. Think about those 4 phases of the bone biology, the hemostatic phase, the inflammatory phase, the proliferative phase, and the remodeling phase, and respect it. Respect dental anatomy, respect the biology. We finished a little bit early. You can go and get your glass of wine. I would like to thank each and every one of you for your kind attention. Once again, I would like to thank Paul and his team, who have done a remarkable job over this lockdown in presenting so many webinars. I would like to congratulate each and every one of you. You've worked very, very hard. Great team. Thank Tipton Training. Thank the British Academy of Restorative Dentistry. You've done remarkably well. And thank you all for your kind attention. If there are any questions, I think Catherine said she wanted to answer them all, or was that incorrect? I'm not sure.
Well, there's no questions for you today, Nigel.
Thank you very much, and good night. God bless everyone.
Yes, thank you very much. We really appreciate you taking the time to do the lecture today, Nigel. Thank you. Have a good evening.
You too. Bye-bye.
Take care.